So these are the steps for treating the intracranial pressure. First, you start with the, of course, diagnosis using the CT. Then the physician bores a hole, and cerebrospinal fluid is drained and monitored. Then sedatives are administered, such as propofol IV. Chemical paralytics are used for Curonium. Then mannitol is given. And you should watch for serum osmolarity to be no more than 320, because afterwards the mannitol will be ineffective. Also, hyperventilating the patient will help, because their oxygen increases and carbon dioxide decreases. When carbon dioxide decreases, it vasoconstricts the cerebral arteries. Then hypothermia, 35 degrees below, keeping the person below 35 degrees, probably decreases the metabolism, decreases the activity, slows down the person so their blood pressure is lower. Then if that doesn't work, this combination of intervention doesn't work, barbiturates are given, pentobarbital, and if nothing else works, compressive craniectomy is an option. So this is just a few steps, and here's some more information. So from the assessment, as a nurse, you would assess for clear cerebrospinal fluid drainage. You would assess for glucose. You check that halo sign, for example, if coming out of the nose or ears. You would suspect that it is cerebrospinal fluid, and you would check it on a piece of paper, that halo sign. The glucose will be around that yellow stuff, around a little red spot. Okay, you would check, you would assess Perla. You check the pupils, Glasgow scale. The smallest is 3, the biggest is 15. So the perfect glaucoma scale is when you walk into the room, they're able to open their eyes. Then you ask them to do something and they perform it for you. That's the okay, for the eyes there's 4. Verbal. If they're able to tell you everything what's happening, good verbal response. Verbal response, that would give you 5. It's the oriented. If they're confused, it will give you 4. And then motor responses. Response. If they follow the commands, you know what? Okay, follow command, they get 6. If they withdraw to pain, then it is 4. Withdraw pain. Then this is 4. That's about it. If they open their eyes to pain, it is 3. To pain, it is 3. And if for verbal response, they are only able to produce sounds, moaning, that is 2. So yeah, this is the glaucoma scale. Cushing's triad, this is the late and bad sign. The person would have all the signs of triad, increased respirations that are irregular, decreased heart rate, increased increased blood pressure, and then temperature alterations. Because their autonomic system control is impaired or altered, they will have increased temperature, neurogenic hyperthermia maybe. So treatment, we would of course monitor them for all those things stated above, and then devices will be inserted into their these patients' skulls. The intraventricular monitoring device, extraventricular, it should be extraventricular monitor device. So sensor sits in the ventricle, can see what fluid looks like, so you can drain the fluid. Evacuation of cerebrospinal fluid, clear, colorless, no red blood cells, 2/3 glucose of plasma. So you would give these patients also antibiotics, because since they have this drain, they will have to prevent the infection, just preventative. Also insertion into the skull is wrapped with maybe iodine. Subarachnoid subdural monitoring, so that can be performed. We want to keep them normotensive, keep their blood mean arterial pressure around 75 pressure, and then venous pressure would elevate the head to 30 degrees, increased intra-abdominal, intrathoracic pressure, or call for suctioning would lead to increase in the intracranial pressure, and we want to avoid that. We want to avoid them coughing, and suction only as needed. Posture, neutral alignment, don't let them be slumped in bed. Don't let them be slumped in bed, because that will affect their blood pressure. Arterial blood gases, no hypercarbia, already talked about it, that it will dilate the blood vessels, and we want to keep them constricted. Temperature, okay, the lower the better. Limit visitors, limit noise to decrease stimulation to the systems. Neurochecks should be done every hour in these patients, every 1 hour. Monitor temperature, hemodynamics due to loss of autonomic regulations, external ventricular drain level 0 to tragus, fourth ventricle of the brain. 7 to 8 millimeters mercury will lead to cerebral spinal fluid to drain, and 7 to 8 millimeters mercury are about 10 centimeters of water on the device, EVT device. You would set it right here somewhere, right here. So monitor intracranial pressure, head of the bed more than 30 to 45 degrees. Now, meds that you would give. So again, you can give mannitol, and you would strive for osmolality around 320, but not more, because it will become ineffective. You can also give 3% saline. That will be hyperosmolar to Lasix to help excrete extra fluids. You would give sedatives, propofol, fentanyl, Versed, and pentobarbital, anticoagulant, an anticalvonsid dilantin or Keppra, antihypertensive, anti-ulcers such as Protonix, and Tylenol. Okay. External ventricular drain care can be placed at the bedside or in ICU or operating unit in situations where patient is unable to control the flow of their cerebrospinal fluid. So tumors, bleeds, blockages. First, when receiving patients from the ER or emergency room, clarify orders, parameters for head of the bed positioning. So they might order, let's say, 35 degrees. Level the drain properly. Physician may order other landmarks than tragus, like the top of the ear. How to record fluid output. When I think every 1 hour, Q1 hour, record output. Patient ICP, post-operative neurological exam. What criteria to follow. So how to set up the external ventricular drain. Position the head of the drain. If altered, will change how much drain coming out. Never change position of patient without notifying primary care provider. Assess. So every time you would try to squish them in, give them a boost in the bed, you would notify the primary care provider. Assess placement by directly following the drain from head. Dressing appearance. Is there any saturation? So yeah, you would chart on the dressing and check if there's any saturation, if there's any bleeding. Follow the drain. Ensure all stopcocks are open until reaching collection chamber, also called Birotrol. So you check the line from patient's head to the monitor on the pole, and you would check that all stopcocks are open and allow the drainage, and that the tubing is still connected to the patient. Once you did that, you would zero it to the guidelines to the patient's ear, and then you would zero to atmospheric pressure too. Okay, and so that's how this drainage system looks like. You have centimeters of water here, and the physician will order the drainage, and I think they set it up themselves. You don't even have to do anything, just have to monitor. Just zero and calibrate. So important info from the drain. You can get hourly output from the drain collected into Birotrol. Birotrol is this collecting chamber, and you gotta empty it hourly. Can measure intracranial pressure. So you also has this little device, a monitor, a sensor that you can use to monitor to assess the blood pressure. No, intracranial pressure. It can either drain or measure the pressure at one time. You can do both at the same time. So pressure transducer. This is a pressure transducer. Transducer. And the monitor will be on the wall. That will show you the wavelengths and will give you also the number. Say it's 17. Leveled at the 0 relative to the patient's tragus. At the beginning of every shift, pressure transducer should be 0 to atmospheric pressure. Stopcock should be closed to the drain that communicates with the patient. The cap should be open to atmosphere and the 0 function should be engaged on the monitor. Situations: to 0 the external ventricular device. Start of a new shift, so every shift you would 0 it. Change of the head of the patient. So if the head of the patient was moved due to repositioning, you would 0 the external ventricular device. Patient left the room for study. Technician entered the room to perform a study. Situation where nurse thinks intracranial pressure recording is inaccurate. So at any time as a nurse you think it's inaccurate, you can 0 it and calibrate. So what is the important things you would document? So documentation in for the hourly neurologic assessments. Hourly drain output, appearance of cerebrospinal fluid, is it clear, pink, bloody, yellow? Hourly intracranial pressure. Abnormal intracranial pressure readings. If you get the abnormal intracranial pressure readings, troubleshoot. We'll check the drains, check the stopcocks, and recalibrate. Check drain itself, ensure all stopcocks are open to transducer itself. Her-level, and re-0 the drain to patient. Notify the physician for such things as low or no output, excessive output, deviation from baseline, intracranial pressure more than 22, disconnected drain, non-functioning drain, change in quality of cerebrospinal fluid, clear or bloody, and new fever.